Evening, everyone. Welcome to the last the OSCE this week, part 3 of 3. I've had a chat with a couple of people during the week, and they said they were going to tune in today. And I'm hi, Kat. I'm not sure whether they've seen some of the other parts of the week, so we'll do a bit of a recap. Just to cover what we've done so far, just so it makes a bit of sense. All of these videos that we do are on, I've put them now on a playlist. So if you search for movement therapy education in YouTube, then there's a playlist of OSCE, clinical reasoning OSCE videos. And I think that there's something like 8 hours worth of this stuff now over the past couple of weeks, past 6 weeks. We've put together quite a bit of CPD resources, quite a few CPD resources for you. So make sure you use these. Hi, Catherine. Make sure you use these for your CPD records. Okay. So what you need to do is do a little bit of a reflective journal about what you've done. Okay. So what you've researched, what you've thought about, how it's influenced your practice. And if you record that down, then you can log it as CPD. And quite often membership organizations now, they have CPD online, so you can just download that reflection then into your portfolio, or just keep it for yourself if anything ever gets checked. Hi Namir, good to see you as well, mate. We'll do a bit of a recap, and then we'll crack on and finish off with this last one. Just to warn you beforehand, there is a bit of anatomy on this that's a bit it's anatomy. And it's anatomy of the thorax and viscera. So if you're having dinner, then I'll give you a bit of a warning before that hits. Okay, so just to give you plenty of warning this time, because there was a few bits the other week that I didn't really let you know about. So here's your warning this time. This is me. If you haven't met me before, my name's Mike, and I run Movement Therapy Education. I'm also one of the master trainers for Prostate UK. And you'll probably see in the offers bit that we've got, thanks, Peter. We've got an offer for a course. So we're running the taping course that we would normally do in one day. We're doing it over 4 days. That's starting next Monday. So if you've never done taping before, then we are doing our very first online course in the UK. It's been running in the US for a while. So I do that, and I'm also a clinic director for movement therapy clinics, and I'm doing been asked to do an Instagram live video for Rock Tape and I think Therapy Expo as well, and I'm going to be covering communication on that one. So it'd be useful. I'm hoping it'll be useful for you for doing online consultations and that kind of thing. So keep an eye out for that as well. I'm not really big into Instagram. It's not my thing, but we'll be advertising it on the Rock Tape pages and on the Movement Therapy Education page as well. So keep an eye out for that if you want to have a look at that. I think with Instagram as well, you can't watch the video over again. So you literally have to watch it there and then. So that won't be for a couple of weeks' time, though. So I'll give you a heads up with that one. So my background's in fitness, and I was a sports therapist, and then became a clinical anatomist, and then an osteopath. So I did my anatomy degree or postgrad first, and then I did my osteo degree. So that's my background, hence the anatomy stuff that we're going to do today. So that's the course, that's the live stream. So 4 sessions over 2 weeks. They're only going to be an hour and a half long. Okay, so we do an hour and a half. There's a private Facebook group. I'll give you some tasks to do. You have to upload your videos to the group, and then I'll assess them and give you feedback, and then you come on the next day. Okay, so we're going to run it like that. So it should be quite interactive, or as interactive as we can make it online. Okay, so this is a bit of a catch up for those of you that maybe haven't seen some of the other sessions this week. So we've looked at a case history, we've picked out some key points, and then we've started to create what we call a sieve. Now, again, for those of you that may not have seen it, that I've just shared the sieve with you. So what it is a way of organizing your thoughts and organizing information into boxes so that you can better deal with all the information that you get, okay? Because it can be quite difficult to, when you're listening to someone's story and you're listening to the case history, to be able to compartmentalize everything that they're saying. And there's a lot, there can be often quite a lot of information, some of it a bit misleading, some of it really crucial. And the sieve helps you to organize all of that information. Well, it helps me anyway, so hopefully it will help you as well. And then we've started to put together a justification for your clinical impression, okay? We're using the word clinical impression because a lot of the guys that watch this are not clinicians, so they're unfortunately not able to diagnose clinical decomposition, exactly. But it's one of those nuances. A clinical impression is near as damn it, basically it's your own thought processes about what is going on with that person. The only thing you're not allowed to do, and I have to stress this, if you're not a part of a regulated profession, you can't say to people what you think they might have, because it's not part of the remit, okay? So but what you can do is you can signpost people to the relevant areas, and you can also become a lot safer in the way that you would manage people. So I had a really good message from one of the guys who contributes quite regularly, and they said that on this case study in particular, they would have just treated this person before doing what we've been doing, okay, and picking out the things that could be seriously wrong with them. So I think that's really good. That's the whole idea with this, is to just get you thinking slightly differently, maybe a bit more in depth about some of the questions that you ask and some of the things that people say, okay? So it's been really good so far. I've had some really good feedback. So plan today is what the heck do we do? So what might be wrong with this person, and then what do we do? So that's where we're at today. So this was the key points from the sieve over the week. Okay, so we had a 55-year-old man who was 5'8" and 14 stone, so that would classify him as overweight. He's a heavy goods vehicle driver and has been for 30 years. Heavy smoker, drinks whiskey most nights, divorced and has no kids. Okay, so the reason why we've got that in there is just a bit of a background about this person's lifestyle, about their kind of day-to-day activities. That there's no mention of any kind of exercise at all. Again, this is one of those things with these assessments, is you don't get given that information. So you would probably ask about it, but in real life, but unfortunately we don't get that information. Lumbar spine, thigh and pelvis on the right side is where he's getting his symptoms, and the right is much worse than the left. He's getting cramping sensations in the leg muscles, but that's been a problem for 2 years. So we've got some layers of issues here. 10-year history of stiffness in his lumbar spine as well. So that would have started when he was 45. Okay. He's got pain and burning into both ankles and the low tibia area, and he thinks they are itchy. Okay, so that's a big clue. We'll talk about that in a sec. Slammed against the wall, hitting the right side of his pelvis, and lower back symptoms in the leg, pelvis and lumbar spine have been getting worse each day since the accident. So what happened was he was unloading a lorry, something really heavy fell on him, and he fell back and hit the right side of his pelvis onto the wall. Okay, and again it mentions his back being stiff in the mornings. So usually works every hour he's allowed to, sometimes more. So he sounds like he's on the road quite a lot. Not a good combination with drinking whiskey most nights. Okay, so we've got a couple of yellow flags going on there. Activity seems to make all of the leg and pelvic symptoms worse. Okay, worst thing is trying to get upstairs, and worsening pain into the anterior right thigh. Okay, so we've got problems in the right thigh on the front. Resting in general helps the symptoms in the leg and the pelvis, so that's a good sign. and he's had urinary urgency for 10 years. Okay, so again, another clue about a particular pathology. And since the accident, Gary's felt constipated. And again, we've discussed this on Wednesday's session about asking these types of questions. It's not usually part of a sports therapy remit to ask about those kind of issues. But on the form that we use, which we send out before the patient arrives at clinic, that's where we ask the questions, so they don't feel embarrassed and you don't feel embarrassed asking the questions. I mean, some of you may have no problems with doing it whatsoever, but that question in our clinic is squared off before they even come in. Okay, they've had a persistent cough for 6 months and they've been feeling breathless. Okay, and their father had a heart problem and their mum had ovarian cancer. So we've got a history of heart problems and cancer. Okay, so we take all of that information and we try and sift through all of the clues in there, and then we came up with this. Okay, so this is filled in a little bit more detail based on some of the things that you guys have said as well over the week. So we've got a clinical, these are the clinical impressions on the left-hand side. So we could have some kind of cardiovascular disease because of his father's heart problems. He's breathless. He's got problems in both of his legs. We don't know if they're swollen. We weren't given that information. But usually if you've got a heart problem, not usually, but one of the signs of a heart problem is that you have edema in both legs. Okay, so it's something to check. And the type of edema you would get is something called pitting edema. I've had to deal with this actually during lockdown. So there was a lady that was a friend of a friend. She was worried about her ankles because her ankles were swollen. So I said, right, okay, if you grab your ankles and hold it there and then let go, is there still an imprint of your fingers in your ankles? And she said, yes. Okay, so because there was, we got her to go to her GP, and her GP thinks that she's got a problem with her heart, so she's going for a checkup. Okay, so you can do some of these assessments even, well, that wasn't even online, that was just over the phone. Okay, so dead easy to do. So Natalie's just asked a question: would you recommend a sports therapist to still ask those questions to be able to refer if needed? Definitely, yeah. What this whole thing is about is creating a safety net for you, so so that you clear those questions off. Yeah. Again, we had a bit of a discussion on Wednesday about has anybody ever kind of objected to answering some of them? And I've had 2 people in about 15 years that said, I'm not answering that because it's none of your business. And I've not treated them because they've just not filled in the forms. So I think it's a necessary safety net for me. What that individual did after not seeing me, I've no idea. They probably would have seen someone that would have treated them. But I'm not treating anyone unless I've got all my questions answered before they come and see me. Okay, so yeah, I think it's absolutely in the remit of sports therapy. And when I taught on the sports therapy degree program, I used to work in the clinics as a clinical tutor. And this is the stuff that I would really hammer my students on, because I knew that they weren't great at it, because even on the degree, we didn't really cover this stuff in great detail. That they were very good at obviously sports injuries, because that's what they've learnt about, but not really good about systemic pathology. Okay, so this was something that yeah, I grilled my guys on. They loved having their sessions with me. So other things with cardiovascular disease, his age, so he's 55-year-old male coming in with back pain and pelvis symptoms. You would think about lifestyle problems and cardiovascular disease, and I'll talk about that in a sec. So we've got he smokes as well, and he's got back pain. So I've put there 3 A's. So that's an abdominal aortic aneurysm. Okay, and we're going to talk about that in a bit more depth in a sec. So what you would do if you thought it was that, more leaning towards that kind of thing, you'd refer him to the GP, and usually the kind of exams that they would have is an ultrasound for the abdominal aorta. And again, we'll cover that in a bit more detail. And the GP would do a cardiovascular examination. So they check blood pressure, they do an abdominal exam, probably check his auscultate the lungs as well. So that they do a full, they should do a full medical screen on that person. And then depending on what they find, they would then refer them to a specialist at hospital. Okay, so that should be the pathway of that individual if you thought it was leaning more towards that. He could have cancer. He could have lung cancer because of the breathlessness and the persistent coughing. Okay, a few of you picked up on that, so that was really good. He's got a family history of cancer. Yeah, so his mum had ovarian cancer, and he may have prostate cancer. He's in the right age range at 55-year-old male. He's had urinary urgency and problems going to the toilet for 10 years, I think they said. So the kind of things that you would expect to go for the GP, again, we'll cover this in a bit more detail. Unfortunately, not very nice, but there'll be a rectal examination at the GP's, and then he would probably get his PSA tested as well. And we're going to talk about that in a bit more detail, just so you're aware of what that process is. We've got COPD. A couple of you guys picked up on that because of the breathlessness and the smoking. So usually, again, that'll be a GP referral. Lung function test would be conducted at the GP clinic, and then you'd expect him to have a chest X-ray as well. Cancer develop over 10 years. It depends really, Peter. Yeah, it really depends on your lifestyle and where the cancer is. And it depends whether it might be a secondary cancer as well. So it might have spread from somewhere else. Yeah, so we're no idea. Okay, there's loads of nuances with that kind of condition. Okay, age or surgical removal of lymph nodes, like the tumor removal, also cause pitting edema in the legs. Yes, age it would do, and definitely removal of lymph nodes, especially if they're the inguinal lymph nodes, because those are the ones that help draw the lymphatic fluid up from the lower extremity. So if you're missing those, if they've been removed for whatever reason, then you are more likely to get swelling in the legs, definitely. Yeah, and also if it's any other part of the body. So if you've had the, usually with a mastectomy, they also take out the axillary lymph nodes, and the arm will be very swollen. Okay, so that's one thing where lymphatic drainage massage can be very effective, because they don't have the lymphatic vessels to bring that lymph back to the heart. Okay, so yeah, that's a good question. Diabetes, that was picked up by some of you as well, because of his diet. He's got a poor diet, he's on the road all the time, and he's got this itching feeling in his lower legs as well, which is a sign of a potential sign of diabetes. So we'd expect a blood glucose test there at the GP's. And this is probably one of the things that where I remember one of my tutors at university telling me this, and it's always stuck with me. Whenever anybody falls, automatically think fracture. Okay, so this guy has had a fall, so something's come off the back of his lorry, landed on him and kind of made him, and the words he used was slammed against the wall, and now he's got a problem with that right side. He could have fractured his pelvis. I mean, I've seen a fractured pelvis with a lot less than that. When I was a kid playing football with our school team, our goalkeeper miskicked the ball and kicked the ground, and he fractured his pelvis doing that. Yeah, so you can fracture bones really in strange situations. But yeah, if there's a fall, then think fracture. Always think that. Okay, whenever someone's fallen, think fracture. Possible soft tissue injuries as well to the right pelvis region. So it could be glutes, glute knee, glute max. It could be some kind of bone bruising as well, potentially. But I'd want to get that fracture ruled out first. Okay, so with this guy, for me, I'd have sent him to A&E for an X-ray of his pelvis and hip. Okay, just to rule out the fracture. That just as a start. Okay, that would have been that, and then I'd have referred him back to the GP for the other tests. Okay, so that's what I would have done with this guy. As you're seeing over the weeks, it's very rare that you're going to get to treat these people because there's loads of stuff wrong with them. Okay, but the whole point of this is not trying to figure out the kind of things that you could do with them, and trying to work out a treatment plan. Is trying to work out, are they safe to treat in the first place? That's the whole point of these sessions. So I just wanted to cover this in a bit more detail. So an abdominal aortic aneurysm. Okay, so I'm going to, so this is information in a second is from the NHS website. So you can search it up on there. I've just put these numbers down here. So these are to remind me what part of the video to have a look at. So I'm just going to pop this video on now. Bear with me a second. So 104.25.
Bones and muscle.
Bear with me a sec. Just going to get to the right section. I'm just going to draw on here a second, just so I can orientate you a bit more. So I don't know what part you got up to. So I'll just show you this. So that bit there, that's your sternum. And then that bit there, that's one of the lower ribs. Okay. And then this bit up here will be the collarbone. And all of this in here, that bit there, that's your, I'm just going to do an H for heart because it would take me ages to do it on the trackpad. And then that bit there, that's the aorta. Okay, and then there's your diaphragm there. So the aorta pierces through the diaphragm to get through to the lower part of the body. Okay, and there's a bit in the diaphragm called the crus. It's like a cross, crucifix. That's what it looks like, and that's where the vessels get to and from the lower extremity to the upper extremity. Okay, so that's just that bit. Let me just play you a little bit more.
And mediastinum undisturbed. Here's the aorta, partly hidden beneath the pleura.
Okay, so hopefully you can hear me now. Is that better? I'll just wait until you give us a thumbs up again. Yep, cool. Okay, good. Right. So now the sternum's been taken off. Okay. And they've taken the covering off from around the heart. So you've got a pericardium that surrounds the heart. And there's the pleura that is the covering on the inside of the rib cage as well. Stops the lungs rubbing against the ribs. So you've got this pleural connective tissue as well. It's very it's like two pieces of glass. You know, when you got glass on the glass and then a bit of fluid in between, and they glide against each other. That's what the pleura is like. So you've got the heart here. Okay. Then this bit here, that's all aorta, all the way through there. Okay. So that, and there's your diaphragm there again. So that now that all that stuff's been taken away, you can see it a little bit more clearly. Okay. So that first bit, that arch of the aorta, and then as it comes down, that's the thoracic aorta. Okay, so that's the bit around the thoracic spine. But that, when you learn anatomy, usually that's all you think the aorta is, but it actually is all the way down to about the level of L3, and then it splits into the iliac arteries, and then when it goes underneath or through the diaphragm, it's then called the abdominal aorta. And that's where we start to get problems. Okay, so I'm just going to go back a little bit, a second, just find out which bit I need to go to. Bear with me a sec. Just get rid of that. Just get back to that point again. Sorry, there's another timing on there that I need to do. So 1:56. Bear with me a sec. I'll just get to that point. Okay, here we go. Cool. Let me just show you that again. Okay, so let's have a look at this.
Now we'll move on to look at the blood vessels of the abdominal region. First the arteries, then the veins. We'll start by looking at the part of the descending aorta that lies below the diaphragm, the abdominal aorta. Here's the posterior abdominal wall with the arteries in place.
Okay, right then. So let's just draw on that again. Okay, so this vessel here, so if I just draw around it there and there, so that bit there, that's your abdominal aorta. Okay, so when you have an abdominal aortic aneurysm, there is usually an issue. So you've got some arteries that come off that abdominal aorta. They go into the kidneys. They're called the renal arteries. And it's usually at that point where you have aneurysms, okay? And an aneurysm is like, best way to describe it is like when you're trying to blow up one of those really long balloons at a party, and you blow as hard as you can, and then all of a sudden, when the air starts to go in, it goes whoop, like that really quickly, and that's what an aneurysm is like, okay? So it's where the blood pressure is so high within the arteries, maybe because they're furred in some way on the inside, that the arterial walls can't take the pressure anymore, so they just and they just start to enlarge. Sometimes it can happen very quickly. Sometimes it happens slowly over years. Okay, this is an abdominal aortic aneurysm is what they call a silent killer. Okay, it's you usually don't get any symptoms until it's too late. And that's when the aneurysm bursts. So just a little bit more on here. So that these arteries coming off it, these are your iliac arteries, okay, and then they split again to form the internal and external iliac arteries, and that then supplies the gluteal area, all of the pelvic floor region, and also forms your femoral artery that goes into your leg. Okay, which we talked about last week. So that's all that stuff. So hopefully that gives you the anatomy in your head. Just going to go back to this again. Bear with me a sec. Let's get back onto these. I'm going to have to flick through again. Sorry. It's reset everything as soon as I've come off it. Okay, so you've got your main aortic branch, and then you've got your descending abdominal aorta. Okay, so, and you can have problems with that, which are aortic aneurysms. All right, so now you know what they look like. So these are the issues that you can have. So a AAA is a bulge or swelling in the aorta, the main blood vessels that run from the heart down through the chest and through the tummy. Okay, and you've seen where they go now. A AAA can be dangerous if it's not spotted early on. It can get much bigger over time, and it can rupture. So if you think about that, you've got the aorta is the main oxygenated blood supply coming out of your heart from the left ventricle, really powerful pump. So if you then have a split in the aorta, which is where all that blood is coming out, you don't have long. Okay, this is something that is extremely life-threatening, and you need to get someone to a hospital straight away. Okay, ambulance, blue lighted. So a AAA can be dangerous if it's not spotted early. It can get bigger over time. Now this guy was 55, but considering his lifestyle, I would have still put him at risk of a AAA. Okay, he didn't have anything obvious in there. But there was a couple of things like with his leg, the symptom in his leg, the breathlessness as well. Those kind of things may point you towards this. So it's similar to to what we had last week. Okay, but the problem's just a little bit higher up. So men over the age of 65 are invited to be screened for this particular condition because it's more likely to affect men in that kind of age range. Okay, so if you've got any patients that are 65 and over, then they should be screened, all right, and they should be screened regularly to make sure that there's no aneurysm, no growing of that aorta. And the ultrasound scan that they do, similar to what females have when they're having their baby checked, they will check the size of the artery, okay, and they'll measure how big it is, and they'll keep an eye on how big it is, okay. So AAAs do not usually cause any obvious symptoms. They're often only picked up when screening is done or when other tests are being carried out. Okay. Some people with AAA have a pulsating sensation in the tummy, like a heartbeat. All right. So if you might feel the actual pulsations of the aorta, yeah, and tummy pain that doesn't go away. So if they've got abdominal pain that doesn't change, or lower back pain that doesn't go away. All right. So again, things that don't go away, problems that don't go with rest, are usually systemic issues. Okay. So something to think about. And then the other thing I just wanted to cover briefly is prostate cancer. So causes of prostate cancer largely unknown, but certain things can increase your risk. So if you're over the age of 50, okay, then you should be getting screened for prostate cancer. And this is it's more prevalent in Afro-Caribbean descent or African descent, less common in Asian men. All right, but also with this guy, because of his cancer history, it would, and his urinary urgency issues, I would have earmarked him to get checked. Okay, so men whose father or brother are affected, a slightly increased risk, and obesity increases the risk, and this guy was overweight. Okay, so there was a few risk factors for him that would increase his risk of having prostate cancer. So you have something called a PSA test done, which is a prostate specific antigen test, and what they will do is they'll test the range of PSA in your blood, and it will increase with age anyway, but these are the normal ranges that you would expect people to have. Okay, so just some background information on that as well. Cool. So there you go, all done for another week. Well done everybody that submitted their ideas on Facebook. It was really good this week. You guys are really getting into the flow of doing it now. What I'm going to do next week, because it's a bank holiday on the Friday, I'm just going to do 2 sessions next week. I'm going to have Friday night off, and we're going to do the Monday night and the Wednesday night, and we're going to they won't be too much longer, the sessions. They'll be about 40 minutes, 45 minutes maximum. Okay, and so we'll give you some things to do on the Monday that we then finish off on the Wednesday. Okay, so we'll just do 2 sessions next week. All right, have a great weekend, and I will hopefully see you all on Monday. Okay, cheers guys.